Our next speaker is Myles Koby, who was a dentist, went back to medical school, trained at LA County and then Washington University, then worked at Maryland University, was at the NIH for many years, and is now a neuroradiologist. And it has given me a great deal of insight into some of the neuroradiology of these difficult conditions. So, Dr. Koby.
Thank you very much for having me. This is an interesting but a little bit of a disturbing talk that Dr. Henderson suggested I present. As an imager, I end up seeing a fair number of people who've been bounced around or have come back after seeing several physicians. Not all of these are Dr. Henderson's patients, but most of them have had problems that really didn't get caught or didn't get picked up. And his question to me is, what do we do about the patient who's symptomatic but comes to me with a normal report? I call it the discordant imaging report. It's basically a symptomatic patient with a normal report, and it's due to either incorrect study, incorrect interpretation, or a study that's just not adequate for what it was supposed to do. And my chief problem or issues are with misinterpretation, and there's a widespread lack of awareness among problems at skull base and hypermobility problems among physicians and among radiologists. I see it really across all the medical specialties, and it's a big issue. And I think it's really another problem in that if we don't recognize it in writing a prescription, radiologists are consultants, and if they don't have any idea what's going on, there's almost no chance a nice diagnosis will come. There's a condition called spinal cord injury without radiographic abnormality. So it's recognized that patients will be symptomatic, patients will have a normal report come back to them, and the patients are very sick. Well, this is largely a function for spinal cord injury without radiographic abnormality. The radiographs look at bones. The injury takes place to soft tissues. So the tool is inadequate to make the diagnosis. There's a number of areas that we may see misinterpretations. It's simply not recognized, or the problems that are recognized are discounted. And among the things here, the most worrisome, and the whole talk to me is kind of worrisome, but the most worrisome condition is having a tethered cord that comes back with the summary of the report, no tethered cord. Well, most of the tethered cords that I've seen have been an occult tethered cord. It's a normal appearing examination with an abnormal patient. In order to make measurements, certain metrics need to be applied, and if they're not applied, there's really a poor chance or low chance of making a correct diagnosis and to communicate with each other about our findings. This is a very abnormal exam, but if we don't have metrics, if we don't have a good way of describing the problems that this person has, there's no way to continue on. So what I'm looking at is a series of measurements between the skull base and the cervical vertebra. The skull base in all vertebrates has a hole in the bottom for the nervous tissue to come through. It's called the Latin version of big hole. And one of the points that we like to measure from is the front edge of that big hole. I may slip and call it basion, but really it's looking the front edge of that hole. The other part is the cervical spine. The first cervical vertebra is a ring. The second vertebra is a bigger body with a upward pointing projection. It's somewhat like a tooth, so it's called a dens or a tooth. And we do a measurement interesting, to get an idea of how much mobility or abnormal relation between the cervical cord or the cervical spine and the skull base. This is a clival axial angle. This is from the base of the skull to the back of that C1. Another measurement, Grab Map Stone Oaks, is an approximate idea of how far the tip of the dens is pushing against the brainstem. Harris measurement is derived from or comes from the trauma literature and is based around ligamentous stability. Less than 12 millimeters may be normal. More than 12 millimeters suggests ligamentous failure. So we're measuring from that tip of the odontoid, or the tip, to that front part of the hole at the base of skull. And we're looking from the back of that C2 vertebra to that, again, the tip, or the anterior part of the great hole in the skull base. And that has to do with position or posture. With loose ligaments like people with Ehlers-Danlos tend to have, the ligaments have failed, the small muscles are trying to protect or hold the joints in place, and that fails. So in this person, with the head tipped slightly back, and the front part of the foramen magnum, the big hole, comes right over the odontoid, or the tip. When we lean forward, things slide forward, and we've got a big space. It suggests ligamentous instability, and the problem is bending of the spinal cord and stretching the spinal cord and pushing on the spinal cord leads to neural injury and symptoms. This is a nice lady who actually had a pituitary adenoma, but persistent headaches and kind of arm weakness, bladder problems, but no one quite listened to it. So this is an initial presentation. This is a pituitary adenoma. We know that for the Grab Oaks measurement, we want to see less than 7 millimeters. Well, this is a little over. We know that a normal range for that clival axial angle ought to be between 150 and 170 degrees. 131 degrees is abnormal angulation. In addition, she's got a constricted posterior fossa. The cerebellar tonsils come through foramen, the hole at base of skull, or foramen magnum. She's got some problems, and this was ignored. She doesn't quite meet the Harris measurements for abnormality, but she's still got trouble. This fellow has a slightly different problem. He has ankylosing spondylitis, which boils down to his ligaments calcifying or ossifying, and his whole spine essentially turns to bone. But his big problem was headaches and inability to swallow. And this is the foramen magnum, the hole at the base of skull. Well, we should never see this. This piece is that odontoid, or tooth-like projection, coming up through that hole. And this is a slice in the cross-section plane, just showing that there's sclerosis, increased density with little cysts or erosions. It's typical of advanced osteoarthritis. And if we apply the measurement criteria, 131 degrees is abnormal. Grab Oaks measurement of 9 millimeters is abnormal, and horizontal Harris measurement of 12 millimeters is abnormal. He's got brainstem impingement. I consider if someone's got abnormal clival axial angle, abnormal Grab Oaks measurement, and they're symptomatic, there's trouble. This is actually a wonderful young lady who's a radiology technologist and ultimately landed with Dr. Henderson, but had upwards of 20 studies, and she was called normal, she was called malingering, there was nothing really wrong with her, she just needed some rest. But if we apply measurement criteria, she has 130 degrees clival axial angle, and Grab Oaks measurement is almost 9 millimeters. She had impingement, which ultimately was fixed, and she had improvement. This is another fellow. He's a cab driver in the Washington area, and he presented to the neurologist with pain in his hands, weakness, and numbness in his left leg. And he'd been seen and dismissed, and this was really his first round of imaging. But what we have is low position of the cerebellar tonsils, we have impingement at the brainstem, and we have this syrinx, which is a collection of fluid within the spinal cord. It goes to the upper thoracic cord. If we apply metrics, he has 125 degrees. He has 6 millimeters, which is close, and 7 millimeters a horizontal Harris measurement. But this is postural, and I think he may have been protecting. Had he bent a little more or moved a little differently, we could have even gotten things further. Here's a nice lady who did come with a few other imaging studies, and she'd been bounced around. And the question is this normal or is this not normal? Well, if we apply metrics, it's abnormal. Looking at this, I can't tell if it's really going to turn out to be normal or not. Odontoid is against the brainstem, and it measures to 130 degrees. It's important that metrics that we know be applied. This one, kind of a challenging study because of the 7 or 8 examinations that I saw of his. This is the one that was closest to facing forward. So when images are less than optimal, it can be distracting to make a diagnosis, but this is his base of skull. So the odontoid is projected up and is impinging upon the brainstem. It simply wasn't noticed. In order to make a diagnosis of instability, we kind of have to move patients around. So in a neutral position, it doesn't really look so bad, but between bending our head way back and bending forward, we have slippage in addition to angulation. And another interesting is to think what else could be going on. This is someone who came to the emergency room after a fall and was kind of miserable, but her CT scan was unremarkable. Her cervical spine didn't show very much. We looked downstairs, and she had fat in the filum terminale. I consider anybody who has a lipoma or fatty changes of the filum and is symptomatic to have a tethered cord. That's kind of a controversial stance at this point, though. This person actually has a little piece of fat in the filum. It's just a little harder to see. Other problems that we can see with symptomatic patients include spina bifida. This is demonstrating that the posterior elements of the sacral spine have not closed, and this is demonstrating some of that soft tissue fluid in the subcutaneous tissues. This is another fellow who's presenting with arm weakness and headaches. And it turns out he's been weak for quite some time. He really had not had medical care. And he's got a very thinned cord. Cord is tethered to that S1 defect with a piece of fat. So this is a congenital tethered cord, spina bifida occulta. And this is that defect again. It's congenital. This isn't post-surgical. I would say that in the Ehlers-Danlos patients that I've reviewed, the tethered cord is almost always occult. There have been a couple cases of spina bifida occulta, but otherwise the cord's going to give a normal appearance, normal location, no associated skeletal abnormalities, and no real thickening or fatty changes of the filum terminale. But it's a clinical diagnosis, and the best way the ways that we're confirming surgical from non-surgical patients is with urodynamics. Neurogenic bladder and urinary retention is a big problem with a stretched cord. Position of conus is kind of important. The literature suggests anything below L2-3 might be abnormal. I figure if it's below L2, L3, it probably is. And it turns out this person is symptomatic with long tract signs. And here's a small lipoma. I missed that one. In order to make a decision about how much mobility is going to be occurring in the cervical spine, this is an upright MRI with flexion extension, and she'd had several studies in the neutral position that didn't show much of anything and was sent home. Somebody had the idea to give her a flexion extension MRI, so we end up with a disc bulging at C5, C6, and between C5, C6, there's 29 degrees motion, or angular motion, and the cord is probably stretched across. Normal motion is less than 12 degrees. This is someone else who has flexion extension with impingement. Between flexion and extension, it's postural. She moves a few degrees, but it's abnormal to start. This is an important case because she had occipital decompression and no stabilization and remained symptomatic. And the horizontal Harris measurement is abnormal. There are a few people who actually do fulfill this criteria, but you have to look for it to find it. Here's a case that's non-diagnostic. There was a concern at C5, C6, C6, C7, C7, T1. C6, C7 is probably abnormal, but on the flexion, we really can't see what's going on, how stable, or what the degree of motion is. Our examinations are really to check the extent of instability. We have to look for motion. For the C1, C2 instability, that's the first and second vertebra. It's a ring, and the main motion there is turning or rotating rather than bending about. And looking at a rotation CT is the optimal way to do this. This is a 25-year-old who was really having problems with uncontrollable high blood pressure and had lost 80 pounds because she was vomiting and couldn't keep food down. And things are definitely abnormal. She had 26 degrees clival axial angle, and there's impingement. But in terms of rotating, this is the ring of C1, and it turns it's 85 degrees in long axis. This is C2, and it's 45 degrees. That's 40 degrees. That's 45 degrees rotation. And really, Punjabi and White suggests 37 degrees is a point where you may start getting vascular impingement and nerve torsion. I think probably 41 degrees is going to be abnormal. And in a symptomatic patient, I consider that a problem. Dr. Henderson tries to see 43 or 44 degrees before committing that is a criteria for surgery. This is 45 degrees, and it's a big problem. And she had remarkable improvement following surgery, and she's now back to work. Overall, our purposes for imaging, as an imager, I want the clinicians to think about why we're doing it. It's to confirm a clinical diagnosis and potentially offer other causes. In the spine, I'm looking to localize segments of mobility, extent of motion, and are there other problems? Is there a dysraphic? Is there a split cord? Is there something tethering? Is there a herniated disc? Are there degenerative changes with spinal stenosis? And thank you very much. Yes?
How often do you have to get flexion extension MRI scans? Because almost all of the MRIs are done supine, and you're looking at these angles in the most non-physiologic position of the patients, a lot of them have symptoms when they're up and about. So if you've got the clinical symptoms listed by the requesting physician, you're getting a supine MRI scan of the cervical spine, and your measurements are all within your range, you've got a lot of different measures, do you then prompt the physician to get the flexion extension gears? How often do you need to get them?
Flexion extension of the cervical spine is usually a prelude to surgery. There are a few there's imaging centers in my area that do these. They're surprised their backlog is pretty significant and sometimes hard to get in. I do not have an open imager to do upright images in flexion and extension. A problem with that, there's all manner of discussion about open imager or not having one. The patients have to spend between 5 and 7 minutes in each of these positions. A lot of them have issues with muscle weakness. They have fatigue. They have lax ligaments, and the small muscles are working very hard to keep them. And it's an extreme position to bend the head all the way forward or bend the head all the way backward. Patients may not be able to tolerate it. I'm doing fluoro images looking at motion, or sometimes x-rays to see how far things will go, but there's no optimal answer. A lot of areas do not have open MRs.
The difference in an upright MRI and an MRI where you're lying down. Can you detect more ligament damage with that?
It looks at the degree of motion in terms of ligament damage or ligament instability. It's an indirect measure because I'm only looking at how far things have moved, how much have things angled, rotated on each other, or slipped. I'm not actually seeing ligaments to the point that I can make a diagnosis. With the MRI, I can see nerve tissue, I can see fluid, I see the outlines of the bones where we don't get any signal from them. I'm poor at defining muscles or muscle problems unless there's a lot of bruising or swelling at that moment. It's poor at looking at ligaments, it's poor at looking at the tendons. There's a lot that my imaging doesn't help with. The CT scan doesn't look at soft tissues as well. I can see fat, I can see fluid, I can see soft tissue, but it really doesn't characterize the tissue near as well. It's good for looking at bones. Thank you very much.